asthma doesn't take a season off. Throughout the year, factors like respiratory infections, allergens, and environmental changes can increase symptoms and the risk of exacerbations, regardless of asthma severity. Hello, I'm Dr. Alexis Smith, a practicing pulmonologist. Thank you for joining me. In this video, I'm going to share with you some information you may not be aware of about albuterol-only rescue, or short-acting beta-2 agonists, or SABAs for short. You may be asking yourself, why are we talking about something that's been the standard of care in asthma rescue for decades? Well, you see, albuterol-only rescue is incomplete. Let's begin by looking at what's driving asthma symptoms. Asthma is unpredictable, with symptoms driven by both bronchoconstriction and inflammation. Patients can experience symptoms triggered by viral infections, weather changes, or allergens, such as pet dander or pollen. This applies to all patients, including those whose asthma is well controlled on maintenance therapy, and who are considered at low risk of an exacerbation. When the body is exposed to triggers, inflammatory mediators such as cytokines are released, activating immune cells in the airway. This results in airway inflammation and bronchoconstriction that drive symptoms including wheezing, coughing, chest tightness, and shortness of breath. While albuterol-only rescue treats bronchoconstriction, it does not address the underlying inflammation. Inflammation contributes to smooth muscle tightening, swelling and thickening of the airway wall, and mucus overproduction narrowing the airway lumen. Together, the effects of inflammation can lead to worsening symptoms and potentially an exacerbation. In response, patients often reach for their rescue inhalers for relief, without addressing the inflammation that's central to driving their symptoms. Let's now turn to what global asthma experts say about albuterol-only rescue. The Global Initiative for Asthma, or GINA, a body of global asthma experts, including US experts, no longer recommends treatment of asthma with SABA alone. While SABAs are effective symptom relief, the GINA 2025 report states that the risk of asthma exacerbations and mortality is higher with increased SABA use, even in patients treated with SABA only. Instead, GINA supports an anti-inflammatory rescue approach that treats both bronchoconstriction and inflammation across all asthma severities. Is it time to rethink your approach to asthma rescue? Treat both bronchoconstriction and inflammation with an anti-inflammatory rescue approach. Airsupra is the first and only FDA-approved anti-inflammatory rescue that treats bronchoconstriction and helps prevent exacerbations. Airsupra albuterol budesonide is a combination of albuterol, a beta-2 adrenergic agonist, and budesonide, a corticosteroid, indicated for the as-needed treatment or prevention of bronchoconstriction and to reduce the risk of exacerbations in patients with asthma 18 years of age and older. Airsupra contains SABA, albuterol, for rapid bronchodilation, and ICS, budesonide, to address the inflammation. Scan this code to learn more about the first and only FDA-approved anti-inflammatory asthma rescue at airsuprahcp.com.
Airsupra important safety information. Airsupra is contraindicated in patients with hypersensitivity to albuterol, budesonide, or any excipients. Asthma may deteriorate acutely or chronically. Continued symptoms after Airsupra or increasing doses of Airsupra may be a marker of asthma destabilization and require evaluation of the patient and their treatment regimen. Airsupra can produce paradoxical bronchospasm, which may be life-threatening. Discontinue Airsupra immediately if paradoxical bronchospasm occurs. Paradoxical bronchospasm frequently occurs with the first use of a new canister of an inhaled formulation. Drugs containing beta-2 adrenergic agonists can produce clinically significant cardiovascular effects in some patients. If these occur, consider discontinuation of Airsupra. Beta agonists have also been reported to produce ECG changes such as T-wave flattening, QT interval prolongation, and ST segment depression. Therefore, as with all sympathomimetic amines, Airsupra should be used with caution in patients with cardiovascular disorders, especially coronary insufficiency, cardiac arrhythmias, and hypertension. Do not exceed recommended dose. Clinically significant cardiovascular effects and fatalities have been reported with excessive use of inhaled sympathomimetic drugs. Hypersensitivity reactions, including anaphylaxis, can occur after administration of albuterol sulfate and budesonide, as demonstrated by cases of anaphylaxis, angioedema, bronchospasm, oropharyngeal edema, rash, and urticaria. Discontinue Airsupra if these occur. Like all therapies containing sympathomimetic amines, Airsupra should be used with caution in patients with convulsive disorders, hyperthyroidism, or diabetes mellitus, and those unusually responsive to sympathomimetic amines. Beta-adrenergic agonists may produce significant hypokalemia in some patients. Decreased serum potassium is usually transient. Due to possible immunosuppression from the use of ICS, worsening of infections can occur. A more serious or fatal course of chickenpox or measles can occur in susceptible patients. Oropharyngeal candidiasis has occurred in patients treated with ICS agents. Monitor patients periodically. Advise patients to rinse their mouth with water without swallowing after inhalation. Hypercorticism and adrenal suppression may occur with very high doses in susceptible patients. If these occur, consider appropriate therapy. Decreases in bone mineral density have been observed with long-term administration of ICS. Regularly assess patients at high risk for decreased bone mineral density. Glaucoma and cataracts have been reported following long-term administration of ICS, including budesonide. Orally inhaled corticosteroids, including budesonide, may cause a reduction in growth velocity in pediatric patients. The safety and effectiveness of Airsupra have not been established in pediatric patients, and Airsupra is not indicated for use in this population. The most common adverse reactions are headache, oral candidiasis, cough, and dysphonia. Airsupra should be administered with caution to patients being treated with strong cytochrome P450-3A4 inhibitors, which may cause systemic corticosteroid effects, short-acting bronchodilators. Concomitant use of additional beta-agonists with Airsupra should be used judiciously to prevent beta-agonist overdose. Beta blockers, which may block pulmonary effects of beta-agonists and produce severe bronchospasm. Diuretics, or non-potassium-sparing diuretics, which may potentiate hypokalemia or ECG changes. Consider monitoring potassium levels. Digoxin, which may decrease serum digoxin levels. Consider monitoring digoxin levels. MAOIs or tricyclic antidepressants. Use Airsupra with extreme caution, as these may potentiate the effect of albuterol on the cardiovascular system. Use Airsupra with caution in patients with hepatic impairment, as budesonide systemic exposure may increase. Monitor patients with hepatic disease. These are not all of the side effects for Airsupra. Visit www.airsuprahcp.com for additional information, including full prescribing information and patient information.